So good morning, everybody. Before I start, I want to tell you one thing. Yesterday was my first day at the course. I was very much impressed by your participation and your enthusiasm. So thank you very much. It was a very good experience to me. So the topic of today is urine microscopy in kidney transplant with focus on BK virus reinfection and BK virus nephropathy as far as urine microscopy is concerned. Urine microscopy is useful in transplanted patients in order to diagnose urinary tract infection in a few minutes. You have a patient who is hospitalized, transplanted patient with fever. The first thing we do is dipstick and urine microscopy to exclude or to diagnose a urinary tract infection. Urological complications are common in patients with a kidney transplant, and again, urine microscopy is very useful in showing hematuria, leukocyturia, and the presence of transitional cells. Recurrence of de novo glomerular diseases, if you have proteinuria associated with dysmorphic red blood cells, or if you just have the appearance of microscopic hematuria with dysmorphic red blood cells, you can very easily diagnose the appearance of the basic disease or the recurrence or de novo glomerular disease. Until a few years ago, it was also used to say that you could make a diagnosis of acute cellular rejection by urine sediment examination when you could find the presence of lymphocytes in the urine. But of course, the diagnosis of acute cellular rejection is a very important diagnosis, and you cannot only rely on a urine microscopy. Renal biopsy is the state of the art for diagnosing this condition. And in the last few years, a new disease turned up which appear to be important in patients with a transplanted kidney. And this is associated, which is due to the reinfection of the subject by BK virus. So the talk of today will be focused on that, on the contribution of urine microscopy in diagnosis this condition. So BK virus belongs to a family of polyomavirus, and there are two main polyomavirus, BK virus and JC virus. BK virus is found especially in patients with a kidney transplant, and it can cause BKV nephropathy and or ureteral stenosis and or cystitis. While JC virus is involved especially in patients with a bone marrow transplant and where it causes hemorrhagic cystitis. Recently, two other viruses have been identified belonging to this family, the so-called KI or Karolinska Institute virus and WOU or Washington University polyomavirus. They have been identified by screening human respiratory secretion. Their role in respiratory disease and renal disease is still very unclear and unknown. These two viruses have in common one antigen, which is called the simian virus 40 antigen, which is used to diagnose this infection in the renal biopsies. These are the features of the polyomavirus, the polyomaviruses. They are double-stranded DNA, icosahedral, without envelope. They have a diameter which ranges from 40 to 44 nanometers. They are composed of 5,000 bases with a genome encoding 6 known proteins, 3 capsid and 3 non-capsid, with also a non-coding area. Epidemiology is very important. The primary infection occurs in early childhood through upper respiratory tract or gastroenteric tract. The route of infection can be oral, through contaminated food or water, or non-oral, air, semen, blood products, placenta, organ transplantation. Latency phase within kidney and ureter. This is very important for kidney transplant recipients, or brain or lymphoid cells. The diffusion is very high, 80 to 90% of general population host this virus in the body. So many of us here, the speaker included, probably have this virus sleeping in the ureter or in the excretory urinary system at the moment. What are the conditions associated with reinfection? There are several: pregnancy, diabetes mellitus, HIV infection, cancer, kidney and other organ allografts. What do we know about BKV reactivation in kidney transplant recipients? The time of reactivation is very soon after transplantation. It's very common during the first year of post-transplant, with a prevalence of 40 to 50%. This is reactivation, which is the conditio sine qua non to have a BKV nephropathy, which mostly occurs in the first 2 years after transplant, with only 5% of cases occurring between 2 and 5 years after transplant. Several factors can influence the reactivation of BK virus. First of all, the intensity of immunosuppression rather than a specific drug. This is an important new information. For many years, investigators have tried to identify which drug was more frequently associated with this infection. Now, it is known that there is no one drug which is especially associated with BK virus reinfection. It is just the intensity of the overall immunosuppression. And besides that, there are synergizing factors. Some of these factors belong to the patient: the age of more than 50 years, the male gender, and the BK virus seronegative condition of the recipient. But also some graft features can favor the reactivation of the virus. If the donor is BKV seropositive, for instance, but also HLA mismatches, or ischemic or immune injury. And the virus features are also important to favor the reactivation. The latent viral load first, the capsid serotype, and how fit that virus is to replicate. How can BKV reactivation diagnosed? So again, we go back to a KDIGO clinical practice guideline, which have been published in the American Journal of Transplant in 2009. We always, as you have seen yesterday, we use guidelines, in spite of the fact that the experts always criticize guidelines. And you will see that we also today, I also today will criticize a bit these guidelines. So what they say about the diagnosis of BKV reinfection? They say there are 3 tools: the testing of nucleic acid of the virus in the plasma, the testing of nucleic acid in the urine, and the possibility of searching for decoy cells in the urine. So let's start with nucleic acid testing in the plasma. I'm quoting what the guidelines say. The use of NAT in plasma provides a sensitive method for identifying BK virus infection and determining patients who are at increased risk for BKV nephropathy. Second, although plasma NAT assays lack standardization, a threshold plasma BKV level of more than 10,000 copies per ml is associated with a 93% specificity for the presence of BKV nephropathy. And what about testing nucleic acid in the urine? A negative urine nucleic acid testing has almost 100% negative predictive value. However, the presence of a positive NAT in urine in the absence of an elevated BKV load in plasma is not associated with increased risk for BKV nephropathy. Hence, a positive NAT in urine requires performance on the blood. This requires patients to return to the clinic for the additional test. Thus, it is suggested that nucleic acid testing be performed only on the plasma and not on urine. So we don't have to waste our money in searching for the virus in the urine. Do that in plasma, it is more than enough. And what about decoy cells in the urine? When testing the viremia is not available, microscopic evaluation of the urine for the presence of decoy cells is an acceptable, albeit non-specific, alternative method. A negative test rules out BKV in most cases, which means that this test has a high negative predictive value. However, a positive test has a very low positive predictive value for BKV nephropathy. It may be inappropriate to change therapy in such patients based on the presence of decoy cells. So they suggest first test viremia, and if you cannot do that, go through the urine sediment examination. And they go further, and they say that patients with a kidney transplant should be screened for BKV with quantitative plasma at least monthly for the first 3-6 months, then every 3 months until the end of the first year. And whenever there is an unexplained rise of serum creatinine, and after treatment for acute rejection, because these can favor the reactivation of the virus. However, not all authors, not all clinicians agree on what KDIGO guidelines say. There are several papers in which it has been shown that the KDIGO guidelines are not accepted. I want to show just one paper, which has been published recently in Transplantation by the Oxford Transplant Unit group. They use intensive surveillance of the program by looking for decoy cells in the urine. With this schedule, transplant to month 2, decoy cells looked for every 2 weeks. Then, for month 3 to 6, decoy cell search monthly. And then from month 7 to month 12, decoy cells every 2 months. And these are the results. They investigated 313 patients, 211 of whom had a kidney transplant, and 102 who had a simultaneous kidney and pancreas transplant. They found that decoy cells were present in at least 2 samples in a period of more than 2 weeks apart in 32 cases. Viremia was found to be present in 24, and when these patients were submitted to biopsy, they found BK-virus nephropathy in 3. What is interesting is the final statement and the conclusions of this paper. The practice of the Oxford Transplant Unit is to use decoy cells assessment for the initial BK virus surveillance, with only those patients identified as having sustained decoy cell positivity, which means persistence of decoy cells in the urine over time, progressing to PCR, which is nucleic acid testing in plasma. With this approach, on the patient population investigated in the paper over a period of 2 years, there was a net saving of 135,000 British pounds when compared with routine PCR surveillance. 135,000 pounds, which is a tremendous amount of money. So this is, to me, in my opinion, the rational approach. You look for decoy cells in the urine. If they are persistently high, at that time, only at that time, you start performing the testing of viremia in the blood. And many papers actually share this view. What are the features of detection of viremia? There is no doubt that it has a high sensitivity, even though accuracy is variable depending on the primers used and BK virus serotypes present in the population. One single test will cost you about 86 pounds. It is not always available in-house, with potential delays obtaining results and limitations in clinical utility. Also in our hospital, we have this test available, but it always takes some days to have the answer. And what about the general features of the decoy cells? They have a high negative predictive value. We will see more about that later. They are very cheap. So we have seen here 86 pounds 1 pound per sample. Can be available within 60 minutes, even 15, 20 minutes in our unit. Can be influenced by the timing of urine sampling and delays on processing, and requires a trained cytopathologist, of course. So, what are, at this point, what are the decoy cells? First of all, why are they called decoy cells? There is an interesting story behind this terminology. In the 50s, in the United States, there was a very famous cytopathologist who was asked to investigate the presence of cancer cells in the urine of patients working in a special type of manufacturing. So he had a technician who was included in the program, and he was in charge of analyzing the urine. And he found that a number of workers actually had in the urine cells which were similar to the cancer cells. But in the end, they found that those patients did not have any cancer. So he called those cells as decoy cells, are the ducks which are used to call the true ducks when one is a hunter of ducks. Okay? So decoy cells means cells which in some way, for their morphology, they remind of transitional cancer cells. Okay? So to describe in the best way what decoy cells are, I will use this paper, which has been written by the best expert on the field, which include Michael Miach, very important renal pathologist, his pupil NUCLEI, and Drakenberg, who has been spending a number of years in working on this subject. The origin of decoy cells is not really clear, because in healthy patients, they probably would like originate from the urothelium, where the virus is hosted, especially from the superficial layers of the urothelium. But in case of nephropathy due to virus, decoy cells likely originate from the renal parenchyma, probably through the ascending route of infection, from urothelium to collecting ducts and proximal tubular cells. What is the morphology of these cells? There are 4 different phenotypes, which depend upon the state of viral replication and maturation, as well as the state of cellular preservation, and hybrid forms, which mean transition forms, morphological forms, between the different phenotypes and are frequently found in the urine sediment. These are the 4 main phenotypes. I don't want to bother you, and I go directly through the images. But before showing the images, okay, these 4 phenotypes are obtained on the basis, have been obtained on the basis of what can be found in the renal biopsies. This is a paper which is published by the group of Miach in 2000 in NDT. These are the main phenotypes which are represented here. Type 1, which is a cell with a ground glass appearance of the nucleus. You see a big and large nucleus. Then we have type 2, when we have a so-called CMV-like decoy cell with a central intranuclear, big intranuclear inclusion and a pale halo around it. Then we have phenotype type 3 with multinucleated cells, which in our experience is rather rare. And then we have type 4 decoy cells with coarse granules of chromatin and the vesicular appearance. And what is the best way to identify these cells? This is the statement of the expert. Decoy cells can best be detected and quantified in standard alcohol, fixed, and PAPANICOLAOU STAIN urine cytology specimens from either smeared or cytocentrifuge, cytospin urine samples. Much is still dependent on the experience level of the pathologist. This means that you have to collect the urine from your patient and send the urine to your cytopathologist. We have cytopathologists in our hospitals. Another possibility, however, again written by the expert, is that decoy cells can also be detected in unstained urine sediment using phase contrast microscopy. This technique, however, requires great experience, but the great experience, as we have seen, is also requested with the stained samples, and quantification of decoy cells is tricky. I don't agree on this aspect. So there are a few papers in which actually decoy cells have been identified and described with the use of phase contrast microscopy. To the best of my knowledge, these are the papers which have been published so far. One from the group of Professor Miach himself, two from our group, and two from another Italian colleague. So, and these are the decoy cells as they are seen with phase contrast microscopy. This is an example of type 1 decoy cells with ground glass nuclear appearance. We see a large nucleus. This is a very good example of type 2 decoy cells with eye bird appearance, big nuclear central inclusion with a pale halo around here and here. This is an example, we don't examples of type 3 multinucleated. This is an example of type 4 cells with a vesicular nucleus and clamped chromatin. Vesicular nucleus here. And also the appearance of COMET-LIKE cells, which are quite typical of decoy cells. So these cells can be very easily identified with phase contrast microscopy without needing any stain, any special procedure, and without the need to involve a cytopathologist. We don't have anything against cytopathologists, but for instance, the cytopathology is not always available, is not present in every hospital, you know. And here are some examples of hybrid forms, okay? Very similar to cancer cells in the urine. And what is interesting, decoy cells can also be seen within casts, which tells us that they for sure come from the kidneys. So a bad sign of possible nephropathy. And another example of decoy cells. You see here type 1 cells within the matrix of casts. So why we use phase contrast and we don't send the sample to our cytopathologist? We do that because it allows an easy identification of the morphological changes caused by BKV virus. And it is based on the same procedures and equipment we use in everyday work in our lab, which is a simple method, fast and inexpensive. It does not require cytologic techniques, which are available only in specialized laboratories. We use the same standardized method to search for this cell, which we use every day for our routine work. So a very simple standardized method, 10 ml of the second urine of the morning, produced over 2 hours, with a standardized centrifugation, 400 G or 2000 RPM for 10 minutes, removal of the supernatant urine of a fixed volume of supernatant urine, 9.5 ml by water pump, resuspension of the sediment in the remaining 0.5 ml of urine, transfer to a glass slide of 50 microliter of the resuspended sediment, which is then covered with a fixed, cover slip with a fixed surface. And we count decoy cells over 50 high power fielded 400 pair. And we give the results as number of decoy cells found on 50 high power fields. And to be sure, and at a certain point, after having developed our experience, we decided to compare our findings with the findings obtained by PAPANICOLAOU STAIN. So we compared 43 samples from 18 patients, and we compared the phase contrast finding with the PAPANICOLAOU finding. We found that same morphological changes were present in the 2 series of samples, even though PAPANICOLAOU was associated with some better details of nuclear inclusions. However, in our hands at least, there was an inconsistent quality of the stain with PAPANICOLAOU, and the procedure were altogether more complex and longer than that obtained with phase contrast microscopy.
Your time is up.
40 minutes versus 15 minutes. Thank you. And in order to push, and these are some images we have obtained with PAPANICOLAOU. You see that we can see the same changes that we were able to see by phase contrast microscopy. And in order to be sure that what we called as decoy cells were actually decoy cells, we performed the electron microscopy of 11 samples containing the so-called decoy cells from 10 patients. And in 10 out of 11 samples, we were able to identify the typical intranuclear viral particles, which was a confirm that actually what we called decoy cells were actually decoy cells. And you see what you see here, how decoy cells appear in the urine when investigated by electron microscopy. They are cells whose nucleus is contain a variable amount of particles, of viral particles, with chromatin coarse granules along the border of the nuclear membrane. Since the time is going on, I don't want to, okay? So an important thing is that these cells can be similar to the cells you can find in the urine in case of a cytomegalovirus infection. So it's not easy to distinguish the two types of cells on the morphological ground only. So one very simple way to distinguish the two situations is, I've seen decoy cells in the urine, so it is most likely that the patient is suffering from reactivation of BK virus, but we cannot exclude CMV reinfection or infection. So the thing to do is to evaluate the clinical setting. Patients with infection of BK virus are asymptomatic. They don't have fever, they don't have extra kidney involvement, they don't have changes in liver enzyme, for instance. But patients with cytomegalovirus are more prone to have fever, to have an extra kidney involvement, and they have also a liver enzyme involvement. And besides that, you have the possibility to test for viremia of BK virus and viremia of CMV virus to distinguish the two conditions. What about decoy cells and BKV nephropathy? There are many papers, a number of papers, which have evaluated the relationship between the decoy cells in the urine and the presence of nephropathy. And the best of these papers is this one, published not by chance in the New England Journal of Medicine in 2002, again from a group from Basel, where Professor Mieci was used to work. 78 transplanted patients treated with FK37 or MMF, 41 were prospectively followed up for 85 weeks. And it was found that decoy cells were present in the 29% of them by 16 weeks of observation. Viremia was present in 13% of them with some delay compared to the appearance of decoy cells. Patients were diagnosed to renal biopsy, and 5 were found to have the nephropathy. So we have a 6% versus 13% of viremia versus 29% of decoy cells, which means that if we compare decoy cells with viremia, we see that the sensitivity of both tests is high, by the positive predictive value for decoy cells is low, and the negative predictive value is very high. So having decoy cells in the urine does not mean that you have nephropathy, but it means that you have a reactivation of the virus, which is a situation which must stimulate you on being more careful, more prone to follow up that single patient. So a summary of the importance of decoy cells compared to nephropathy, not just reinfection, is that the positive predictive value of decoy cells in predicting nephropathy is low. However, it can be increased to more than 90% if the number of decoy cells is high, if the shedding of decoy cell persists over time, if decoy cell casts are found in the urine, if viremia is positive and renal dysfunction develops. Now I have a case report, but since there is a shortness of time, I will stop here. If you have questions, then we can decide what to do with the case report.